Hello everybody, welcome to PGOG postgraduate class in Obstetrics and Gynecology, and today we will see the next part of primary amenorrhea, clinical approach to primary amenorrhea. First part of primary amenorrhea, last class we had seen pathophysiology. Now we come to the clinical approach to a case of primary amenorrhea. Just as a revision, how we define or when do we start evaluating a girl, considering her, diagnosing her as a case of primary amenorrhea is no secondary sex characters and absence of menses by the age of 13, no menstruation by the age of 15, or no menses after 5 years of initiation of breast development. In bracket, I have given 14 and 16 because some of the books are still mentioning this as a time limit. But most of the recent advances, they do believe that there is a reduction in the age of menarche all over the world, and that is why the definition has changed from 14 to 13 and from 16 to 15. Secondary amenorrhea, as you know, it is no menstruation for 6 months in a previously menstruating woman, or no menstruation for a total duration of 3 menstrual cycles. Now this slide is just to show that though we divide amenorrhea into primary and secondary amenorrhea, there are so many conditions which are seen responsible for development of both primary as well as secondary. There are certain conditions which are specific for primary amenorrhea, such as gonadal dysgenesis, Mullerian-Ogenesis, androgen insensitivity syndrome, outflow tract obstruction, constitutional delay, and congenital absence of endometrium is a very rare condition. Specific for secondary, we can say Sheehan syndrome, Asherman syndrome, cervical stenosis, secondary to any cervical surgery on the cervix, such as cone biopsy. But there is a long list of conditions which can present either as primary or as secondary, such as pregnancy. Whenever there is amenorrhea, it is a dictum that even if it is primary amenorrhea, we need to exclude pregnancy because ovulation occurs before onset of menstruation. PCOS, premature ovarian insufficiency. Now this is the newer terminology. Previously we used to say premature ovarian failure or premature menopause. Now we call it as premature ovarian insufficiency rather than failure. It is considered to be a better terminology because it has been seen that around 20% of the women diagnosed with a premature ovarian failure do show some ovarian activity in future. And that is why rather than saying it as a failure, it is better terminology is to call it as insufficiency. Thyroid disorders, hyperprolactinemia can lead to both primary or secondary. Same way, these are the rarer causes such as CNS tumors, functional hypothalamic such as because of the stress, weight change, eating disorders, excessive exercise. All these can be leading to either primary or secondary amenorrhea, such and non-classical congenital adrenal hyperplasia, Cushing syndrome. So this we should not be focusing only when we talk about primary amenorrhea. Why I wanted to show this slide to you is we should not be focusing only on this specific causes, because so many times it can be a case of a hypothyroidism, and here we will be searching whether it is a case of Mullerian-Ogenesis or whether it is outflow tract obstruction, and on the other hand it will be a simple hypothyroidism, and if we detect and treat it, the girl will start menstruating. It is just an example, and that is a reason why we should not be neglecting this second group of conditions which are also seen leading to primary amenorrhea in many patients. Now, always in clinical practice, as we say, the careful physical examination gives a clue about diagnosis, and especially it helps us to do the specific investigation rather than subjecting a single patient to a whole battery of unnecessary investigations. So here, if there is a sudden weight loss, weight gain, vigorous exercise, it can be the amenorrhea of hypothalamic origin. Chronic renal disease can lead to amenorrhea. How? Because there is a less of prolactin clearance by the kidney, and it leads to hyperprolactinemia, leading to primary amenorrhea. Head trauma, diabetes, chronic diseases such as inflammatory bowel disease, they do affect HPO axis and that leads to amenorrhea. If there is headache, vomiting, visual disturbances, convulsions, then CNS pathology needs to be suspected. One should never forget to rule out pregnancy in any patient of amenorrhea, and certain drugs are there which are responsible for the presentation. Patient might present as a case of primary amenorrhea. Lower abdominal pain, urinary complaints in cryptomenorrhea, hyperandrogenism features suggestive of polycystic ovarian syndrome, breast secretion. It can be because of hyperprolactinemia, pregnancy, or even 20% of PCOS can have mild hyperprolactinemia leading to breast secretion. Severe nutritional, physical, emotional stress, as we have already seen, can be the cause for hypothalamic amenorrhea. On examples, short stature, suggestive of Turner syndrome, reduction in BMI might point towards anorexia nervosa, that is nutritional cause for amenorrhea. More obesity with increased waist hip ratio can go in favor of PCOS. Warm skin, tachycardia, exophthalmos tremors can be suggestive of hyperthyroidism, and opposite can be suggestive of hypothyroidism. Progressive hirsutism with virilism one should rule out. Late onset congenital adrenal hyperplasia or virilizing ovarian or adrenal tumors. Acanthosis nigricans suggestive of insulin resistance as a cause of amenorrhea. No thelarchy, then more possibility of gonadal dysgenesis or constitutional delay. Good thelarchy but no adrenarchy. It goes more in favor of androgen insensitivity syndrome. Lower abdominal lump is there. Outflow tract obstruction is a possibility. Inguinal masses, that is a testis which is present on descended testis in patients of androgen insensitivity syndrome. And a small labia majora might be seen whenever there is a gonadal dysgenesis. This is an important slide. It shows how we should go ahead whenever we get a patient of primary amenorrhea. Suppose a patient walks in our OPD, and how to go ahead, because whenever we see a patient, sometimes we are at a loss and we feel whether it is hypothalamic cause, whether it is pituitary, whether it is ovarian, and then sometimes it might be confusing whenever we see a patient. So systematically, for evaluation of a case of primary amenorrhea, this hierarchy has been suggested that first we should go for uterus and ovarian tract evaluation. If it is normal, then we go for the evaluation of ovarian function. We see whether the ovaries are normal or whether there is any ovarian dysfunction. Then if it is normal, we go for the to rule out pituitary dysfunction, and last is a hypothalamic. That is why it is said as a level 1, level 2, level 3 and level 4 of evaluation in a patient of primary amenorrhea. And I think that practically whenever we see a patient, this systematic stepwise evaluation helps us for the clear for not missing anything important, and as well as for the clarity of our thought. So what are the disorders of uterus and outflow tract in primary amenorrhea which are present in oocysts? First is Mullerian oogenesis, second is androgen insensitivity syndrome, and third group is outflow tract obstruction. In Mullerian oogenesis, we have two types, type A and type B. Type B is more common. Type A, there is a centrally situated symmetrical small knob-like rudimentary uterus, and usually endometrium is non-functioning, and presence of fallopian tubes might be there. Whereas in type B, it is a asymmetrical rudimentary uterus. On one or the other side, we can see small asymmetrical mass like uterus, but still no functioning endometrium, and associated other anomalies might be the renal anomalies, horseshoe kidney, or skeletal abnormalities are also commonly seen. So type B is more common as compared to type B. Androgen insensitivity, it is important to remember that not every patient will have a classic presentation as a good thelarchy, no adrenarchy, and masses in the inguinal region is too typical, and it might be seen in a case of complete androgen insensitivity. But there are certain patients where it can be partial. Partial means some axillary and pubic hair growth might be seen in these, and that is why in these cases diagnosis ultimately needs to be confirmed by doing a karyotyping. In outflow tract, there it can defect can be at the level of hymen, there can be a transverse vaginal septum, cervix might be absent, or there can be a vaginal agenesis with a functioning uterus presenting as a case of cryptomenorrhea. So evaluation for this uterus outflow tract, stepwise we should go. We should first take this history. We should see how are the secondary sex characters, which in these cases, uh, then as the ovary is normal, HPV axis is normal, secondary sex characters are normal in these patients, except in cases of androgen insensitivity syndrome, where there is asymmetrical secondary sex characters. It is said as asymmetrical because thelarchy is good, whereas adrenarchy is less, absent or less. Lump in lower abdomen, masses in inguinal region can help us to come to a provisional diagnosis. Bulging hymen on curve or Valsalva manure almost clinches the diagnosis of imperforate hymen. And if it is not there and there is a mass in lower abdomen, it is, or we are suspecting whether there is a Mullerian agenesis, it's better to do examination under anesthesia for speculum examination, and we can do PR examination in the same sitting. Ultrasonography will help us to know abdomen as well as pelvis, because renal anomalies can be there in some of the patients. And MRI sometimes helps better as compared to ultrasonography if there is a doubt. For example, whether it in a transverse vaginal septum, whether it is a septum at the upper one third, middle one third, or lower one third of vagina. For these conditions, MRI might give us a better information. X-ray, skeletal X-ray especially to see for the anomalies seen in cases of some skeletal abnormalities are seen, especially in type B of the Mullerian agenesis. Then laparoscopy is rarely needed. Usually this much of a diagnostic information is sufficient, and we can directly go for chromosomal analysis to differentiate between a Mullerian agenesis or androgen insensitivity syndrome, because these are the two conditions where vagina is very short or absent, and we need to differentiate and confirm whether it is 46XX in Mullerian agenesis or 46XY in androgen insensitivity syndrome. So this is a flow chart. Cyclical pain and lump is there. We go along the line of obstructive pathology. If it is not there, then we see whether the adrenarche is present, absent. No adrenarche favors diagnosis of androgen insensitivity syndrome. Presence of good secondary sexual characters, Mullerian agenesis is the possibility. No, when we see for the how is the hymen, how is the vagina, cervix, body of uterus, and endometrium, and if we find everything is normal, that means level 1 is normal. Uterus and outflow tract is normal, and it is an indication to proceed with level 2, that is evaluation of ovarian function. Let us first see what are the ovarian problems or problems related to ovarian function, or the disorders of ovarian function, which are seen in a case of primary amenorrhea. Gonadal dysgenesis is a very common cause of primary amenorrhea, and textbooks do give it around 40% of the cases can be because of gonadal dysgenesis in a case of primary amenorrhea. Second is premature ovarian insufficiency, and third is anovulation. So in gonadal dysgenesis, Turner syndrome is most common, and usually 45XO leads to primary, whereas whenever there is a mosaic, and commonest mosaic is 45X, 46XX. In these cases, some of the follicles are still there, and they do present in majority as patients of secondary amenorrhea rather than primary amenorrhea. In pure gonadal dysgenesis, we can have 46XX or we can have 46XY. Whenever there is a 46XX with deafness, then it is called as Perrault syndrome. When it is 46XY pure gonadal dysgenesis, then it is called as Swyer syndrome. In patients who have premature ovarian insufficiency, the cause can be, there can be a chromosomal defect. It can be because of autoimmune disease, or radiotherapy, chemotherapy damaging the ovary can lead to premature ovarian insufficiency and primary amenorrhea. Anovulation is a less likely cause, less common cause, but still we should not forget that We need to rule out PCOS, thyroid dysfunction, and hyperprolactinemia even in a patient of primary amenorrhea. Now, this is a WHO classification which is very commonly asked by examiners also, and it is expected from postgraduate students that you should know what it is. There are given three groups were initially suggested by WHO, and then later on fourth group was added. Group 1 is hypogonadotropic hypogonadism. That means here even FSH is normal or low as well as estrogen is low. So hypogonadotropic. Group 2 is normogonadotropic, where normal estrogen, normal FSH, normal prolactin. Group 3 is hypergonadotropic, that means there is more of FSH. But hypogonadism is low estrogen. And last is in patients of hyperprolactinemia. So some of the examples are hypogonadotrophic hypogonadism, hypothalamic level. There can be a life-induced hypothalamic dysfunction or constitutional delay where patient will present with low or normal FSH and low estrogen. PCOS where everything is normal. Gonadal dysgenesis is a classic example of hypergonadotrophic hypogonadism where FSH is raised and estrogen is low, and pituitary adenoma is one of the common cause of hyperprolactinemic anovulation. See that group 2 and group 4 it is given as anovulation, whereas the terminology which is given for group 1 and group 3 is hypogonadism. So that is how this WHO classification is there, and it though it is more of a theoretical classification, it helps us to understand the pathophysiology in these cases of primary amenorrhea. So what is happening is hypogonadotrophic is less GnRH and low or less FSH, normal prolactin, and here there is less estrogen also. And because of that, thelarchy also will be in initial stages or absent. And most common is a constitutional delay, which can be present as a common example of this. If everything is normal, GnRH normal, FSH normal, estrogen normal, it can be seen as in PCOS. Hypergonadotrophic is ovarian failure. So whenever we say ovary is at fault, what is happening is negative feedback to the pituitary is lost, and that leads to the more and more secretion of FSH, and that is why we call it as hypergonadotrophic hypogonadism. And last is hyperprolactinemic anovulation. When you are more prolactin, there is less FSH, and that leads to the anovulation in some of the patients of primary amenorrhea. So this is a HPO axis, and CNS tumors also, or CNS lesions also can affect the hypothalamic function. And if there is a disorder at this level, CNS hypothalamus pituitary, it leads to hypogonadotropic hypogonadism. And if the problem is at lower level, ovarian level, then we call it as a hypergonadotropic hypogonadism. To evaluate the ovarian function or to know whether the ovaries are functioning normally or not, there are 6 indications or investigations we can say, and I have grouped these investigations into 2 parts. First 3 are less reliable, whereas the next 3 are more reliable indicators of ovarian function. First is serum estradiol level, and we might think that serum estradiol level must be a very good indicator of ovarian function, but unfortunately it is not so. If it is less than 40 picogram per ml, we can assume that ovarian function is low, but it has been seen that lab results are very erratic with this serum estradiol estimation, and that is why it is not a reliable indicator of ovarian function. Next is, since last so many years or generations, we are using progestogen challenge test, where we give progestogen medroxyprogesterone acetate 10 milligram twice a day for 5 days, and if patient gets withdrawal bleeding, that means progestogen challenge test if we do, and if there is a withdrawal bleeding, that indicates that there is a circulating estrogen and endometrium is already estrogen primed, and that is why it is seen as an indicator of estrogen status. But unfortunately with this test there are many false positives, negatives. Especially what is happening in polycystic ovarian syndrome is, though estrogen level is usually in normal limits, still in around 20% of the patients there might not be any withdrawal bleeding when we give a patient this progestogen. The reason which is given is because this endometrium in PCOS is chronically subjected to increased androgen levels in PCOS, and that is why it fails to respond to progesterone, and that is why there is no withdrawal bleeding in these. Might not be withdrawal bleeding in some of the patients of polycystic ovarian syndrome. Abundant cervical mucus, which is watery, is indicative of estrogenic status, but it is also not a very reliable indicator. As well as what is the, though thilarchy we say is a sensitive indicator of estrogen status, still because of the peripheral conversion of androgen to estrogen, it might not be exactly giving us the indication about the ovarian function. It gives the indication about the overall estrogenic status in the body. More reliable investigations, fourth is to see for the endometrial thickness by doing ultrasonography. And whenever endometrial thickness is more than 6 millimeters, it assures us about a fairly good ovarian function, and less than 6 millimeter is indicative of a ovarian dysfunction. Next is follicle stimulating hormone. Levels more than 20 international units per liter. These are quite indirectly giving us strong evidence that the ovarian estrogen secretion is less. But still, there are certain conditions, such as there are certain FHS secreting tumors, or there are certain enzyme deficiencies, such as aromatase deficiency, 17 alpha hydroxylase deficiency, where it can be raised in spite of ovaries having the follicles. That is why it is not that reliable. What is more reliable than FSH is, that is why, anti-Mullerian hormone. If it is significantly reduced, that definitely indicates that ovarian function has depleted or ovarian failure is already present. Whenever AMH is more than 5 nanogram per ml, we know that it is one of the indicator that of a polycystic ovarian syndrome. So what are the features? In short, low estradiol, negative progesterone challenge test, scanty cervical mucus and no thilarchy, thin endometrium, raised FSH, and low anti-Mullerian hormone. Now here, what we want to see is what are the peculiar features which help us to diagnose a specific condition for whenever there is a ovarian dysfunction, disorder of ovarian function. So Turner syndrome, all these stigmata we know since our undergraduate days, and it will be seen. And ultrasonography will show a strict gonad. Pure gonadal dysgenesis, how we differentiate? Height is usually normal, whereas Turner is always having a short stature. If it is Turner mosaic, then the height might be more. But primary amenorrhea, usually the patient has Turner syndrome, 45XO, and all these associated features might be seen. Whereas in premature ovarian insufficiency, as opposed to secondary amenorrhea, whenever there is a primary amenorrhea, hot flushes and dry vagina is usually not seen. Hot flushes because of the initial patient has estrogen and then there is a hypoestrogen level. But here patient has never experienced normal estrogenic level, and that is why hot flush is not seen in a primary amenorrhea with premature ovarian insufficiency. Ultrasonographically, we can differentiate between these two, that here it is a strict gonadis, very small ovary with fibrous tissue, and whereas here menopausal like ovary is, where we can ultrasonography differentiate between cortex and the medullary portion of the ovary. Level 3 is evaluation of pituitary function. That means we have seen uterus and outflow tract, it is normal. If we have seen for the ovarian function, all the investigations are pointing towards a normal ovarian function, then the level 3 is evaluation for pituitary function. Investigations which help us are follicular stimulating hormone. Less than 5 international units per liter is suggestive of a pituitary failure at the level of pituitary. Even if it is 5 to 10 and estradiol is low, less than 50 picogram per ml, then also it is suggestive of pituitary dysfunction, because here, though FSH is there, it is biologically inactive, and that is why in spite of FSH being between 5 to 10, estradiol is low is significant. It is also suggestive of a pituitary dysfunction, and in these cases, the important investigation is to do a MRI, brain MRI with contrast. We can get pituitary adenoma, benign tumors, malignant tumors, pituitary hyperplasia. All these can be diagnosed with the help of this MRI. Now all the levels are normal, suppose. Say pituitary MRI is normal. Then the last which remains is hypothalamic, and commonest is functional hypothalamus amenorrhea, FHA. Functional hypothalamic amenorrhea. It is a diagnosis of exclusion. There is no specific test to evaluate hypothalamic function. All we have to first rule out uterine and outflow tract dysfunction, ovarian dysfunction, pituitary level dysfunction, all three levels normal. Then we can say that as a diagnosis of exclusion that it can be a case of functional hypothalamic amenorrhea. Usually there is a history of extreme stress, emotional stress might be there, physical stress might be there, excessive history of excessive exercise might be there, eating disorders, anorexia, nervosa like disorders also, low BMI, and typical history will be there. And in these cases also it is a hypothalamic, that GnRH pulsatility secretion is altered with all these conditions. So it is associated with low FSH, low estradiol. Rarely there it is one condition is idiopathic where no cause is found. Why there is low FSH, why there is low GnRH pulsatility is also abnormal. That is idiopathic. Or there can be a Kalman syndrome as a differential diagnosis where there is anosmia with GnRH secretion disorder. So this is just to repeat. Level 1 is hierarchy is first whenever a patient comes to OPD, we need to see how the uterus is and how the outflow tract is, whether there is any obstruction, how the endometrium is. If it is normal, then we go for ovary. The test for ovarian function we do, as we have seen, the test can be divided in more less reliable and more reliable. If that shows that there is low FSH and low estradiol, then it is an indication to go ahead and do the pituitary MRI level 3. If it is normal, then we consider it as a hypothalamic cause, functional hypothalamic amenorrhea, if everything else is normal. Thank you so much. Next class we'll see management of primary amenorrhea. Thanks a lot.